Well, I'd like to, whilst everyone is coming in, welcome you all to National Thrombosis Week 2024. We've been doing this for well over 20 years, and it's offering you a very warm welcome. We have an extraordinary number of people who've signed up. We've got nearly 2,500 people who are registered with us. We have got them from every sphere: surgeons, physicians, nurses, pharmacists, you name it. And we've got 49 presenters in 21 sessions over 3 days. And we aim to keep these presentations fairly short. We know that people's concentration spans aren't what they were. I hope that you can dial in and catch a few of the sessions. We've got some really super ones coming through, so please have a look and see what would suit you. And I really, at this stage, want to thank all of the presenters and the people who've been having ideas for sessions for coming forward to us. So this session is about the challenges in the diagnosis of VTE. It's much more of a back to basics session. And I'd very much like to welcome my co-speakers. We've got Dr. Matthew Fay. He's a general practitioner based in Bradford, and he's been involved in service redesign of cardiovascular services, including the redesign of Bradford VTE services to make it completely community-based. He's going to start the session to talk about presentation in primary care. I'm going to, and sorry, I should have said, I'm Beverley Hunt. I'm the founder of Thrombosis UK and a trustee. And I will be talking about presentation of VTE in hospital care. And then lastly, we have Professor Catherine Nelson-Piercy. She's Professor of Obstetric Medicine and a consultant obstetric physician based in London. She has an illustrious career. She's the immediate past president of the International Society of Obstetric Medicine, and she's editor-in-chief of the journal Obstetric Medicine, and she's produced loads of publications, as one would expect. So she is going to talk to us about diagnosing VTE in pregnancy. So I think without much further ado, we should start. I'm going to hand over to Matt to talk about presentation of VTE in primary care. If you have any questions, please do put them in the chat and we'll try and deal with them. Thank you. Good luck, Matt.
Thank you very much, Beverley. I'm just going to share my screen. Bear with me a moment. So hopefully you can now see my slides. So I'm going to talk about general practice. I'm a GP, have been for over 30 years. So I'm just going to look at pulmonary embolism from, or VTE from a general practice perspective. I've not got many slides and I'm not going to spend long talking. I hope and have more time for the discussion. So just my declarations. We know PE is a problem. We know that it doesn't always present in a classical way. We know that there is often a delay, but that delay is costing lives. And we need to try and think how we're going to actually improve the situation. Now, I am invited to speak on many topics to my colleagues in general practice. And usually they're around cardiac disease, cardiovascular disease in its various formats. So I think VTE in general practice is a little bit like the Fight Club. Just first rule of the Fight Club, don't mention the Fight Club. I invariably now will send back to people who ask me to talk and say, well, you know I could talk on AF, but couldn't I talk on VTE actually? And it's a good way to keep your calendar open and let people politely turn you down. But one of our problems is that we don't talk about it in general practice a lot. And I think when particularly living in an environment with people like Professor Hunt, you find that in hospitals it is much more of a talk, a conversation. Well, you don't actually have to go very far to find that general practice has got an issue. So if we look at Regulation 28, where we can go to the website, just put in something as simple as thrombosis, what you find is immediately you'll find a load of reports from our colleagues in the coroner's office around the fact that we need to be looking at how we are looking at the VTE, and we need to be trying to make changes. Many of the Regulation 28 start with a GP, start with a problem where somebody is presented knowing they have a problem and not being able to get beyond the GP, and often ending up then in casualty or in certain situations in a much worse state. So we know there's an issue out there. Now, one of the issues, of course, is the demand on general practice. And I'm not sitting here trying to be an appeaser of the fact that general practice is busy, but general practice is busy because we've got fewer GPs, and therefore more GPs are looking after more patients, and we're doing that in more consultations. And if we're getting that kind of flow through the practices, then it's more likely that things might be overlooked. And so we can understand a little bit about where things may be happening. But if we're doing all these appointments, what is actually happening in general practice? Why do people go to see the GP? Having been a GP for many years, I'll tell you, some people just seem to come for the chat. And if that's a service that we need to offer, that's a service we need to offer. But why do we actually consume this massive amount of GP appointments? Now, number one is actually hypertension, which for me, as a pathway redesigner, I think that's something that could be easily managed by people who aren't general practitioners. Our community pharmacists could take up some of that work. But what you then find is respiratory tract infections, and a little bit further down in our top 10, we've got cough. Now, of course, for all those in the audience who deal with PE on a regular basis, we know it causes breathlessness and respiratory symptoms and cough. Now, this is actually an incredibly common reason why people come to see the GP. So if they're coming with these symptoms, why aren't we recognising the problem? And I think some of that comes down to the pathway of care. So when we look at what NICE tell us to do, and we should always look at NICE, of course, they tell us that if we think there's a thrombosis, if we think there's a DVT, then we've got this lovely pathway of things that we can then follow and work our way through. However, this does have a slight flaw to it from any clinician's point of view, which is that you have to think of the diagnosis to start with. So we have to consider that thrombosis might be our issue before we get onto our pathway. And we know from work that we did in Bradford some years ago, where you had to code the Wells score to be able to progress down our DVT pathway. When we looked at codes of 1 and less of a Wells score, we couldn't find any. So essentially, if a GP was thinking about thrombosis and doing a Wells score, that may have helped them think about whether the relative risk that this person might have. If they were doing the Wells score, they weren't documenting it before they went down that low pathway. And of course, that's not even the function of the Wells score. So if you've thought of thrombosis, there should have been 1s, 0s, and negative numbers, because of course that's part of the pathway. Even if you have that low score, we need to investigate further, but I'm going to leave that to other people to discuss. So when we think of thrombosis, what kind of things should we be thinking of? And of course, it's the symptoms. And this is where we get into our problem once more, because the symptoms of PE, the symptoms of DVT are mimicked by other conditions, and they're not very specific. So we struggle with the fact that when somebody comes in and says they're breathless, it could be the fact they've got a cold, it could be their COPD, it could be like me at the moment with my hay fever. You know, there are so many different issues here that it can be difficult to work out exactly what's going on. So we have to try and get people to think of thrombosis. Now, preparing for this talk, of course, I came across a paper which just the title leapt at me, because it is definitely the way when I talk to my colleagues in general practice, you tend to think of pulmonary embolism, which is when I can't think of anything else. Maybe it's a PE. That patient who comes to you and is ill and you can't quite work it out, and a few days later you find out that they've died, you think, that was probably a PE. When we can't work it out, we tend to go in this direction, and we know that this is actually causing delay. But one of the major features that this study did point out was when the GP, when the clinician just had that gut feeling that it was a PE, that's usually when they got it right. That Gestalt feeling that the patient's not right, then you're trying to push yourself into the direction of thrombosis, and maybe that's how it would help us out. When we look at the BJGP, they also looked at PE, and then what they found was actually there's often a delay from presentation to actual diagnosis. And Thrombosis UK, working with GERFT at the minute, is doing an audit in general practice to try and look at that delay and quantify that delay to see if there's any patterns in how people present it that may help us push further into how we can get GPs to think of thrombosis. What the Emperor study tells us, of course, is that if you're going to do PE, then the best way to do this is to have a well-structured pathway. So you actually get onto things quicker, and that might help us get to a diagnosis faster. So let's look at some of these pathways, particularly when you're thinking of chest pain. So if you go on to Google and just put in chest pain pathways UK to see what pathways come up, you get examples like this, and this is a lovely pathway from Blackpool Vic, and of course in Blackpool there is a lot of vascular disease up in Blackpool, but their pathway is essentially a cardiac chest pain pathway. It takes you through a very nice flow of all that troponin, and then tells you to send everybody to rapid access chest pain clinic or give them some Gaviscon. So it's there as a chest pain pathway, but it isn't all chest pain. And then we can look at the Royal College, and again their chest pain pathway is actually a cardiac chest pain pathway. And if we continue to push this idea that if it isn't cardiac disease, it's not significant chest pain, then GPs will learn that, and we need to make sure that we're pushing just beyond the idea that it's just always about cardiac disease. So this is a lovely pathway that I found, which looked at chest pain in a much more holistic way. And of course, we've got the cardiac syndrome right in the middle of it. But if we look just to the right, we see the pulmonary embolism is there as well, with some risk tables. I have to say that we need to be careful about that Wells score again. If you've thought about a pulmonary embolism or a VTE diagnosis, then you cannot just do a Wells score and say, well, the score's low, it's not there. We have to make sure that we've progressed, as the NICE guideline says, to do tests even in that low risk cohort. If our Gestalt is saying this could be a thrombosis, that we actually proceed down a pathway and do something as simple as a D-dimer. So what about anginal pain? Well, anginal pain is dead easy, isn't it? This is why I did cardiac disease as a GPSI. It's relatively simple. We've got very clear rules. Most people present in a very, very similar way, and so we get there quite easily. But then we go back to that list of symptoms for PE, and they're so vague. So what we have to do is make people think of thrombosis in a different way. So what I'm trying to push into my colleagues in general practice is when you're seeing somebody with a painful leg or with breathlessness, have a think about the basics. Just jump back in there and think, could this be a VTE? Have they got previous risk factors? And these are always cited in those regulation 28. There's always something in the history that seems to have been overlooked. And so we need to get back to these. If you've got risk factors and somebody's presenting acutely, think of thrombosis. even those transient risk factors. You know, often, again, in those regulation 28s, you've got that broken limb that started the issues, should have got the alarm bells ringing for us. And we need to then think of thrombosis again. So where do the risk scores come in? And of course, we do have the Wells score, which is endorsed by NICE. But NICE is very, very clear that if you do a Wells score and the score is low, then you should be proceeding to another test. It's not what the Wells score has told you is in this person where you thought it was thrombosis, you don't have to rush to the scan, but you do have to exclude the diagnosis. And the way that they talk about excluding that diagnosis is D-dimers. And we all know the issues with D-dimer. However, are we doing it? Even if we don't like the test in the acute setting where you have somebody you thought could be thrombosis and the score is low, so in Wells DVT it's 1 or lower, then we should be doing a D-dimer. In PE, if it's 4 or lower, then we should be doing a D-dimer. And how should that D-dimer be done? Well, NICE actually looked into this and said, well, actually, you should actually be considering this to be a point of care test. And when they looked in detail at the pricing of a point of care test, for DVT, it actually is a cost-effective model to have D-dimer in community hubs or within large practice bases, and PE, similarly, it was a cost-effective intervention. So we've got pathways. We need to make those pathways broader so that they encompass the idea of pulmonary embolism and chest pain and DVT into leg pains. But even if we do that, we need to make sure that we're safety netting and telling our patients what they should be looking out for, saying, well, I don't think this is a thrombosis. However, if your symptoms progress, if other things develop, then you must come back to me. Or if it's acutely changing, you must attend the local ED service to get this sorted out. So really important to safety net those patients. So if you've done the Wells score and you've abused it slightly and you're not going to do the D-dimer, at least safety net it. And that's actually mirrored in what we're hearing from our friends in NHS Resolution, who of course have to pick up the tab every time we get something wrong and the patient comes back saying that they feel that they should be recompensed for the damage. And they're saying to people, think of thrombosis, make sure you safety net well. Make sure they've talked about their concerns. If they say, I think I've got a thrombosis, listen to that, because they may have seen thrombosis up close, closer than we have as a physician, and understand the symptoms that they're dealing with. So, in quick summary, what is our problem in thrombosis? One of it is training into general practice. We don't teach enough into general practice about thrombosis, particularly when we compare that to stroke and heart disease, where we've seen very large national campaigns recently. We need to make sure that's an ongoing discussion. General practitioners have a very short attention span, not because we're bored, but because the next problem and the next issue and the next issue flows into us. You can go a week with a new pathway landing on your desk every single day. So it's important that we maintain our discussion and our leadership into our general practice. Think about diagnosis and risk scoring. Think about maybe how you would set up a point of care D-dimer service within your area. The result is needed there and then for the patient. It's not good enough to make a blood appointment in 2 or 3 days' time where the result's going to be back in a week. If you're designing pathways for GPs, keep them simple, keep them on one side of A4 because they're going to get stuck on a notice board and ignored. But if there's anything on the back, then that's definitely not going to be seen. Try and keep the intervention as simple as possible for the GP. Refer, use an anticoagulant, whatever that intervention is, try and make sure it's kept simple, and really just work to make sure the patient understands why we're doing what we're doing and how they can help us if symptoms develop. And just to promote Thrombosis UK, we do lots of patient resources about this. So having these kind of things to hand within your consultation room will allow you to have that conversation with the patient as well, and give them something to take away that they can reference afterwards. And with that, I'll hand back to Beverley as the chair.
Well, thank you, Matt, for your very clear messaging. It's great to hear that you're so keen on VTE, because you're obviously offering great leadership among your colleagues. There are some questions in the chat. They're not particularly pertinent to VTE, but someone is asking about the Frail study for AF and switching from warfarin to DOACs. And I think that they are asking you because they probably very rarely have access to a general practitioner. So shall we just deal with that first, and then move back? Should I read out the question to you? It says,
if you would,
post-Frail AF study, which looked at Frail AF patients on vitamin K antagonists and switching to DOAC, may be associated with more bleeding and perhaps safer to remain on a VKA as a GP. Would this impact? ? So really, it's just asking, has Frail AF changed your practice?
To be fair, Frail AF hasn't changed my practice, because I left lots of older people on VKAs anyway, but I had a very comprehensive VKA monitoring service, which involved a lot of domiciliary visiting for those frail patients. And I think that as we've seen a contraction of some of the VKA monitoring services, because so many people have moved on to DOACs, I think you've got to balance that risk of the patient who would be easily taking their DOAC in a home environment, who may struggle to get to a VKA monitoring service. So in Frail, the VKA, the warfarin was well monitored. And what we know from previous AF studies with warfarin control was very variable in AF patients. So I think if you're going to, you have a good service and somebody's got a well-controlled INR, I would question why you'd want to move somebody in older age with kidneys which are going to do interesting things with very little metabolic strain. I think you've got to really question why you'd want to move them to a DOAC, and always involve the patient in that discussion. Obviously, a lot of our VKA patients in older age weren't keen on moving to DOACs. That could be because they were new, but I think some of it came from the fact they liked the idea that the level of anticoagulation was monitored by somebody. So it's a conversation always.
Not just the older ones, some of the younger ones, it gives them a feeling of control, which is often really important in patient care.
In some of the younger ones, Beverley, you've also got to think about the restriction that it puts on their life when they have to get to a VKA monitoring service.
Then there's a really open-ended question. Is there an appetite for point of care testing in primary care? Can we think of just about D-dimers and diagnosis of VTE?
I think that primary care is in a very, very sensitive area at the moment. I think that anything that looks like secondary primary shift of work, it needs to be handled very carefully. I think if you're going to have that conversation, you need to make sure the costs are held by the path lab, because that's where the money was originally. So you can't be with an increased cost to general practice, but I think you could sell it to general practice if the costs aren't involved, on the understanding that they'll make a better diagnosis for their patient. It'll be a quicker diagnosis for their patient, and they can be reassured when that person walks out the door that their D-dimer was well within acceptable range, which means that thrombosis isn't likely. So it's how you have the conversation with general practice and make sure there isn't a shift of cost into general practice, because that won't get anywhere at the minute.
Okay, well, this is the whole issue around general practice and secondary care is politics at the moment, isn't it?
On money, there's no money, so
no money.
Everybody's trying to save their pennies.
So then there's another question allied. How is education about VTE for GPs being addressed? Do you think there's major teaching going on, or do you think we need to go out to them?
I think we need to go out. I think that we know, Beverley, that there is a passionate group of thrombosis interested clinicians, but it's a relatively small pool that we have to draw on. But we need their leadership out there in general practice to show that VTE is an issue, and that if we question our patients well, safety net them well, and do simple testing, we can protect our patients. But it comes from clinical leadership, not from ICS leadership, not from a pathway of law. It comes from people talking to people.
Okay. There seems to be a major sub-discussion going on in the chat. So it's all around what are D-dimer levels post-op? And of course, they're high. So there's still a huge lack of understanding about D-dimers. D-dimers will go up if you go for a run, if you've got inflammation, and of course they will in VTE. And we would expect them to be raised post-operatively. So the Wells score isn't validated post-operatively. So if you have a clinical suspicion of VTE, you should really be going ahead and discussing with the radiologist the need for a scan.
I mean, when you've got the risk factors, Beverley, piling up, I think it's a brave clinician who uses an unvalidated risk score when you've got so many factors suggesting that your gestalt is right and this is a VTE. And of course, D-dimer, its major power is when it's normal in excluding a diagnosis. So yes, you may do more scans, but that's the risk of hitting the diagnosis more often. So it's not when the D-dimer, what artificially raises the D-dimer, it's what artificially lowers the D-dimer that I think is more than so.
Yeah. Here's another question specifically for you. Is there any role and value of the PERC score in PE assessment in primary care?
I'm not a big fan of PERC. PERC was validated in a low risk environment. So if you're going to use the Wells score, this is a group that you're then going to say Wells score less than 4. I'm going to do a PERC score. Is that going to stop you doing a D-dimer? I don't think it should stop you doing a D-dimer. So I think it helps you in who should I send to the hospital, maybe. Yeah. But beyond that, I think PERC in general practice is.
Thank you. It hasn't been validated in a general practice. It's really only been validated in emergency departments. And I think about 5%
in low risk populations
departments will use it. Yeah.
It's popping up more and more though. So I appreciate the question because you are seeing it more and more.
Is there anything else you want to say to a lot of secondary physicians who are online?
The one thing I would say is that what we need is leadership, and leadership doesn't come from non-clinicians, it comes from passionate clinicians to talk about thrombosis, and you will find the GPs will respond to them.
Okay, well, thank you very much, Matt, for presenting the GP perspective. We're hoping you'll stay online for questions maybe at the end that we can all discuss. I'm going to go on and talk about diagnosing VTE as a secondary physician. Thank you, Joe. Joe's doing my slides for me because I'm incompetent on Zoom getting the slides up. It's much easier to do it this way anyway. Okay, so we're going to move on to the next slide, please. So just to remind everybody that VTE are not a small problem. We know we've got problems of death. We know that about 30% of those who've had unprovoked VTE will have recurrence. We've got ghastly post-thrombotic syndrome. This picture shows a particularly poor case. And of course, the chronic pulmonary hypertension, possibly in 2%. Next slide, please. And when we think about the general body of knowledge that we have about VTE, we've moved such a pace from when we started this charity in 2002. So we've got all the risk factors, here they all are. Next slide, please. And we have in the UK a fantastic collection of guidelines on diagnosing and treating VTE. Our NICE guidelines, I know, are much admired across the world. And of course, there are things like the ASH guidance and some European guidance. Next slide, please. So we have lovely diagnostic algorithms. Matt's already shown you the diagnostic algorithm for PE. And once you suspect a DVT, you apply a well score and a D-dimer. Next slide, please. And we've got the well score well validated in emergency departments for DVT and PE. Next slide, please. Here's our PE pathway. Once you think about it, we've got very complex diagnostic pathways, but they work. Next slide, please. And we also now have got modern treatment for VTE. So if we look at practice in the UK, the bulk of people offering care in secondary care are using direct oral anticoagulants as the first anticoagulant in their patient if they are fit to go home, if they have a low PESI score, if they've got PE. Next slide, please. So we know such a lot. And we also know that when we see VTE, if you're looking at populations, about 2/3 will present as a DVT, and another third will present as a PE. And we know that the problem with DVT is that the proximal DVT are the ones we're concerned about more than the distal, because they have a higher rate of causing PE. And about 10% of proximal DVT will go on to cause symptomatic PE. And we know that PE can be fatal almost immediately, or patients can die later, obviously without treatment. So in the UK, with our population of somewhere between 60 and 65 million, there's estimated to be about 60,000 episodes of VTE per year. That's 1 in 1,000. Next slide, please. But what we haven't discussed, and where I think the biggest problem is getting people into these fabulous pathways that we have. What are the criteria that lead a clinician, maybe a triage nurse in the emergency department, or general practitioner, or a hospital doctor to think that this might be a VTE? Next slide, please. So let's just consider a couple of stories. These aren't unusual, certainly for my clinic, but I tend to see tertiary referrals. People are quite upset because they haven't had their diagnosis made initially. So this is a lady who's 4 weeks postpartum. She'd had a major postpartum hemorrhage, and remember, that's a risk factor for getting VTE, and she had a 3rd-degree tear, which was sewn up. And then day 5, she developed pain in her left leg, and she saw the midwife while she was still in the hospital, and was told it's probably a muscle sprain and not to worry about it. After that, she got more and more pain, and she went to the GP 3 times and was told, oh, it can't be serious because there's no swelling, there's no redness. Because, of course, when you open a surgical textbook, there's a picture of a DVT with a big fat swollen leg. And then she saw an osteopath. Osteopaths are very well trained in the UK, who thought it probably could be a DVT, and sent her to the emergency department. And of course, she had a DVT. Next slide, please. So this is a 19-year-old who's known to have asthma, and she started on the combined oral contraceptive pill. Combined oral contraceptive pill increases the risk of VTE 2 to 3-fold, and became increasingly short of breath 2 months later. And we know if you have a VTE on the pill, most of them occur in the first 6 months. It's unusual to see a late one, but they do happen. So because of her increasing shortness of breath, she was treated for asthma, and her shortness of breath was so bad, she was admitted to her local intensive care unit and was still short of breath on discharge. She was readmitted again to intensive care, but this time it was thought she was having panic attacks, and psychiatrists were brought in. So she was eventually discharged and still short of breath, and collapsed at home, and brought back by a 999 call to a different emergency department, where the physician thought it through and did a D-dimer, which was enormously high, and a scan showed multiple PE. So two missed cases because no one was thinking about VTE. Next slide, please. So it's as though people won't put you down the pathways unless you've specifically got swelling in your leg. Let's have a look now at other areas. Next slide, please. So let's just think about what are the medical textbooks saying. So they usually say PE symptoms, shortness of breath and chest pain, maybe increased heart rate, respiratory rate. You may cough up blood, but of course we know that hemoptysis is very unusual in PE. DVT, swelling in the legs, changing colour, and at the bottom, pain. Next slide, please. And then when we go on the internet, boy, what do we see? Well, we see lots of pictures purported to be DVT. And I'd like you particularly to look down to the bottom left. That we have on the right, we have a very scarred and pigmented champagne leg, which is typical of post-thrombotic syndrome. So that leg has had multiple DVT with a lot of scarring and pigmentation to get that champagne leg. This is not acute DVT. And when we look at the others, we can see there's change in colour and swelling. So we have this message being reinforced. It's swelling, or it's change of colour, and giving pictures that aren't even appropriate. Next slide, please. This one particularly unusual. This probably is a DVT, but it's very unusual for DVT. Next slide, please. So let's have a look at the websites. If you were somebody worried about having a DVT, this is the patient website, and it says quite rightly, the clinical diagnosis of DVT can be very difficult. And many DVTs progress to PE without DVT being clinically apparent. Well, we know that because we have a third of VTE presenting with PE, so they've never had any symptoms of DVT. We've got limb pain and tenderness along the line of the deep veins. I think quite difficult to elicit that symptom. Once again, we've got swelling of the calf or thigh, pitting edema. So again, more swelling, distension of the superficial veins, increase in temperature, and skin discoloration. So once again, we've got lots more swelling, changing colour, very little on just having pain. Next slide, please. This is what our glorious NHS website says. I must say I pulled this off yesterday as I did the patient details. So symptoms of a DVT are throbbing pain in one leg, usually in the calf or thigh when walking or standing up. Not sure about that. Swelling in one leg, warm skin around the painful area. Now that's not a DVT. Warm skin around a painful area is superficial thrombophlebitis, where you've got inflammation of the superficial veins. Red or darkened skin around the painful area. Once again, superficial thrombophlebitis. And lastly, swollen veins that are hard or soft when you touch them. So again, that's superficial thrombophlebitis. So we've got the wrong signs and symptoms of DVT on the NHS website. And Joe, I hope you're listening, but we're going to have to write to them on behalf of Thrombosis UK after National Thrombosis Week to point out that their signs and symptoms of DVT are incorrect. Next slide, please. This is the Mayo Clinic. Again, I pulled it off yesterday. Much better. Leg swelling, leg pain, change in colour. But it's putting swelling first. So the message coming from the internet, got to have swelling really. Next slide, please. So I've just put this picture up of the veins in the leg to remind you about the extent of them. Next slide, please. And also let's think about the concept of DVT. So if you've got a DVT that completely includes one vein and there's no collaterals, then you will get leg swelling. But we know that most DVT don't start like that, and there are usually collaterals. So if you've got a partial occlusion, so you've got a bit of clot floating around, it's affixed the endothelium probably at the bottom and then waving around in the venous system, and there's collaterals, you won't get any swelling at all. Next slide, please. So we come back to this issue that we know when we have VTE, a third presenters PE alone. So we obviously have silent DVT in those patients. And I think the other flip of that coin is that if you do postmortems of people who actually have DVT or who die of PE, some have residual clots in the legs without any symptoms. I'm saying the same thing. So DVT can and often are asymptomatic. Next slide, please. But I think really what I want to push home is this study by Dan Quinlan. It's quite old now, but he did an analysis of 10 studies, nearly 6,000 patients who had hip and knee replacement, where they had all had some form of venography within 3 weeks of having had the surgery. They were all treated with enoxaparin. That's irrelevant because what we want to look at here is the ratio of symptomatic to asymptomatic DVT. So when we look at the hip fractures, there was about 2.7% rate of symptomatic DVT. By the way, this is very high, and we wouldn't expect to see this rate these days because we get the patients up, we mobilize them early. The rate is now much lower. But when we look at the asymptomatic, so they showed up on the scan, but there were no symptoms or signs, 13%. And then when we look at the knee, 1.8% symptomatic, again, very high rate we wouldn't expect to see now, asymptomatic, 38%. So that for every symptomatic DVT, we've got 10, 20 times the number of asymptomatic. So I hope my pushing is making you think asymptomatic DVT are much more common than symptomatic, by which they meant swelling. Next slide, please. So more DVT will have no swelling compared with those with swelling, but could there be other symptoms? Now, I did show you that picture of the leg veins, and want to remind you that the iliofemoral vein starts in the tummy. Why aren't we talking about signs and symptoms in the abdomen? Next slide, please. So we should be thinking in unexplained abdominal pain, especially in the iliac fossas, of the possibility that that patient might have an iliac vein thrombosis. The first case report I can find describing this is from the Netherlands Journal of Surgery in 1987. Next slide, please. It's actually been described more frequently in pregnant women. So this is a case of a pregnant woman who had right iliac fossa pain and didn't appear to have appendicitis. And it took a while for the penny to drop that actually she had an iliac vein thrombosis. And of course, we know iliac vein thrombosis are more common in pregnancy than outside of pregnancy. Next slide, please. And unfortunately, this is a very real, tragic case from only a couple of weeks ago. So it's a 13-year-old, presents with right iliac fossa pain in the emergency department. And of course, they think this boy must have an appendicitis. So he has an ultrasound scan and a white cell count. The white cell count is normal, and the ultrasound scan shows no inflammation in the appendix. So he gets sent home. There's no explanation for the pain, but gets sent home. And unfortunately, collapses at school a few days later, pulseless, with a massive PE, with tragic results. So I'm hoping this type of case is going to make you remember that iliac vein thrombosis can present with iliac fossa pain. Next slide, please. So we come back to this original description of what's in the medical textbooks, and I've amended it because this is what I think it should say. Next slide, please. As far as PE is concerned, Matt has talked about the fact it can be quite a subtle presentation, and you need to consider PE in anybody where you can't quite explain their chest symptoms. But as far as DVT is concerned, the books have got it wrong. The websites have got it wrong. The number one symptom is pain alone or even asymptomatic. And the swelling of the legs and the change in colour would be quite late features, but usually not present at all. So we need to, when we talk about DVT, say the number one cause, the number one symptom is pain without any other problem. Next slide, please. So we did about 10 years ago with the British Society for Haematology look at what our medical students are learning about haematology in the United Kingdom. And it would be an interesting study to do worldwide. And we found that there was highly variable teaching going on. We presumed that VTE would be part of haematology training. Maybe some of the medical people or surgical people might teach something, but we presumed it was in haematology. And we have some universities offering 2 months and others offering 2 days. And I suspect this whole myth that DVT present with swelling and redness is just being perpetuated in our country and globally. And we have got to do something about it to stop people being missed and tragically ending up with long-term problems or even dying. Next slide, please. So my last slide, I think we have a major problem with the clinical diagnosis of VTE. We need to recognize the commonest presentation is pain. And we actually, I think, in this day and age, still need to do some research on the signs and symptoms of VTE. We could do this retrospectively or prospectively. And we need to teach these new findings to postgraduates and medical students, and also to nurses and midwives. And for now, we need to maintain the low index of suspicion of VTE and consider any unexplained symptoms and signs in the leg or chest should be considered to be VTE until proved otherwise. So thank you for listening. And I just wondered if there were any questions there specifically for me. No, I don't think there are. So I am going to now move on to Professor Catherine Nelson-Piercy and ask her to talk about us about diagnosis of PE in pregnancy, and then we can have a chat at the end. Thank you. Over to you, Cathy.
Thanks, Beverley. Can you just shout out if you can see my slides okay, Beverley?
Fabulous. Great.
Okay, thank you very much for those first 2 talks, which sets the scene nicely, and for the person in the chat who asked about D-dimers in pregnancy. I'm going to talk about the difficulties and dilemmas and controversies about diagnosing VTE in pregnancy. But firstly, I'm going to show you these data, which this is not the last Embrace report. This is actually an interim report, which includes the deaths from 2020 to 2022. And you can see that there has been an increase in the maternal death rate. The blue line is the death rate that would have happened without the COVID deaths. And this dotted line are the indirect deaths, and the dashed line are the direct deaths, of which PE is one. But what is important in the context of this lecture is not that the death rate, maternal death rate is increased, but that now, for the first time, PE is the leading cause of maternal death in this country. It's even more common than COVID, and it's overtaken cardiac disease as the leading cause of death. And there are 2.17 deaths per 100,000 maternities in this country. That is very sad for me to say as the lead developer of the guideline for thromboprophylaxis in pregnancy, because clearly it's not working. Or it is working, but the baseline demographics are changing. We have women are older, they are more obese, they are more comorbid. And of course, not the COVID deaths, by the way, the COVID VTE deaths are counted in COVID, but COVID and lockdown did lead to delays in diagnosis of many things, cancer and PE. So as you all know, pregnancy increases the risk of VT about 4 to 5 times. This is particularly marked postpartum, twice the risk after elective caesarean section, 4 times the risk if that caesarean section is an emergency. And overall, if you look at absolute instance of a first ever venous thromboembolic event in pregnancy, it's about 100 per 100,000 person years. And if you look at the timing of that first ever VTE, it's most common in the early postpartum, by which we mean the first 6 weeks, but it's also more common in the 3rd trimester. It is. Now, contrast that with deaths from VTE. So if we look at deaths from VTE, they don't occur in the 3rd trimester, interestingly. They are most common postpartum, but in the UK at any rate, the antenatal deaths are in the 1st and 2nd trimester. Now, there are several reasons for this. Partly, we have active thromboprophylaxis in the 3rd trimester. Women are under the care of obstetricians who risk assess them, have a low threshold for using thromboprophylaxis. Excuse me. But the other issue is that in the 1st trimester, women haven't booked for pregnancy care. They haven't been risk assessed. They are under the care of their GP, or they are under the care of early pregnancy units. And many of the women who die from VTE in the 1st trimester, as Beverley has highlighted, the diagnosis is simply not considered. And this is a real gap, I think, in our management. Of note, most of the women who died were obese. Some were very obese. Worryingly, some are very young. And over half of them, when the assessors looked at the care, they thought that different care could have prevented that woman's death. Contrast, as I've said, the deaths from VTE, which occur postnatally and in the 1st and 2nd trimester, with instance of VT, which occurs postpartum and in the 3rd trimester. This also has implications for thromboprophylaxis, because our highest risk women, those who've had previous VTE, those with high-risk thrombophilias, they need thromboprophylaxis from the time of a positive pregnancy test, not from the time of booking in with their midwife. So on to what I'm supposed to be talking about, which is the diagnosis of VTE in pregnancy. So sorry, everyone. Right, so diagnosing DVT is not difficult with ultrasound, as Beverley said, if you think about it, and Doppler ultrasound is validated in pregnancy, but it's really diagnosing PE that is much more controversial. And I still believe that D-dimers are fairly useless in pregnancy, and I'll explain why. There are a few exceptions to that. And the clinical prediction rules are also useless. So why am I making such a bold statement? So for DVT, ultrasound can miss below knee, and the solution there is that if the ultrasound's negative and you've got a high level of clinical suspicion, don't anticoagulate, but repeat the ultrasound in 3 to 7 days, and then if it's extended, you'll see it. But if you suspect an above knee an above ilial ligament, inguinal ligament DVT, then you should do an MR venogram, which is available in most hospitals now. The problem with PE in pregnancy is spotting the needle in the haystack. Breathlessness is extremely common in pregnancy. Chest pain is quite common. Dizziness is quite common. And we cannot irradiate all these women who present with breathlessness or chest pain or dizziness. So it relies on a very good history. Now, this is quite an old study now, looking at the confirmed PE in those who are present with suspected PE. And if you suspect a PE outside pregnancy, then your pickup rate will be about 12%. But if you suspect a PE in pregnancy, your pickup rate is only 4%, probably because your threshold for imaging is lower because you are worried about PE in pregnancy, because you've remembered that I've said it's the leading cause of maternal death. And if you look at this systematic review of prevalence, they agree with these data that in non-pregnancy, your pickup is up to 15 to 20%, but in pregnancy, it's only 2 to 7%. In passing, I'm just going to remind you that chest x-rays, CTPAs and VQ scans are all safe with regard to the radiation dose that the fetus is exposed to, and at most increases the background rate of fatal cancer less than 15 years by about 0.006% per milligray. So it's negligible. It's negligible even if you were to do a chest x-ray, a CTPA and a VQ. However, the radiation to the mother's breasts is significant. Modern imaging techniques can reduce this, but it's still much more than that received from a VQ scan, which is virtually zero. So we can't just CTPA every pregnant woman. Now, I'm going to talk about D-dimers. These are some studies that have been done looking at normal ranges of D-dimers in pregnancy, and for some of them, they've compared that with the non-pregnant range. And you can see that they are very, very variable. They're in different populations, and there are different multitudes of backgrounds that people use for the first, second, and third trimester cutoffs. And one of the best studies, I think, is this Irish study, which looks at the D-dimer reference ranges in pregnancy, and it concentrates on first trimester, second trimester, and third trimester. And you can see that in the third trimester, this dashed line is the cutoff for normal range outside pregnancy. And virtually all pregnant women will have an abnormal D-dimer in the third trimester. And even if you take a doubling of the normal range or 1.5 the normal range, a significant proportion of women will have an abnormal D-dimer. Conversely, in the first trimester, most women actually will have a normal D-dimer if normal is taken as the non-pregnant normal range. But more importantly, a pregnancy evolves, and this is not normal ranges saying, 1.5 times, 2 times. You don't suddenly move from 28 weeks to 1.5 times to 2 times. It's a gradual increase in your D-dimer as pregnancy progresses, and therefore having artificial cutoffs when you've got a moving target is, in my opinion, never going to work. So I thought I'd illustrate. Oh, now we've got a tractor outside. Sorry about this. So this is a 35-year-old woman in her first pregnancy. She's delivered. She's 1 day post-delivery, and she's complaining of chest pain. The obstetric SHO requests a CTPA because they think chest pain postpartum must exclude a PE. They think the chest X-ray is normal. And they ask the medical registrar to review, and they tell the medical registrar the chest X-ray is normal. The medical registrar was my obstetric medicine registrar who reviewed the chest X-ray, and it was not normal. Now, I'm not sure if you can see my arrow, but this is a pneumomediastinum here with this line here, and in the right supraclavicular fossa, you can see the surgical emphysema. Why am I showing you this chest X-ray? I'm showing it to make the point that you must never leave out the chest X-ray when investigating a query PE, because the chest X-ray can find an alternative explanation for the breathlessness or the chest pain or the collapse. So it's an essential investigation, and it prevents you needing to do a CTPA in many cases. So not all chest pain and breathlessness is a PE. The next case, these are both real cases, by the way. The next case is a 33-year-old lady who had an IVF pregnancy. She had a normal vaginal delivery, and like Beverley's case, she'd had a postpartum hemorrhage due to uterine atony and a retained placenta. She developed left-sided chest pain on the first day postpartum. It was sharp, it was pleuritic, it had improved by the morning. There were no associated symptoms of breathlessness. Her saturations were normal on room air. She wasn't tachycardic, her blood pressure was normal, nothing to find abnormal on examination. The pain was reproducible on palpation, and the impression was that this was musculoskeletal pain. She was reviewed by a medical SHO who confirmed the history. She complained of pleuritic pain or deep inspiration with a positional variation. Again, observations were normal, examination normal, and it was felt that this was a low probability of a PE. She might be anemic from the postpartum hemorrhage, and it was likely musculoskeletal. They then made the mistake of discussing it with the medical registrar, who said, "We'll send a D-dimer." And that D-dimer was normal. Remembering that this woman is immediately postpartum. She was anemic. The other blood tests were normal. Her CRP is raised. Her troponin was normal. I saw her and I thought, there is not an alternative explanation for this woman's chest pain. I didn't think it was musculoskeletal. I wasn't put off by the negative D-dimer. I did a VQ scan and it was abnormal. Now, okay, it was only a small subsegmental PE. Does that matter? My point for sharing this case is that the negative D-dimer, which people will often say as well, D-dimers aren't helpful because they're always positive, but if they're negative, isn't the negative predictive value good? It is good, but it's not 100%. And do you want to miss a small PE? So there have been two really important studies published which argue that a combination of D-dimer using pregnancy ranges and clinical decision rules in pregnancy can reduce the number of women that we have to scan. And on the face of it, these are really clinical practice changing papers, but they're not as simple as they seem in the conclusion. So this is the first one. This is the Canadian study, which used a combination of the Geneva score alongside D-dimers. It took a long time to do this study, 8 years. And the conclusion of their study was that they were able to rule out PE without scanning or adverse outcome in 12% of their women. Most women, therefore, did require scanning. So they're not reducing a large number of scans. This is the Dutch study, and again, very similar. They used a modified years algorithm and again, D-dimer. Again, similar number of women, 500 pregnant women with suspected PE, 18 hospitals, 5 years, and they were able to rule out a PE without scanning or adverse outcome in almost 40%, 2/3 of women. Now that's becoming really interesting, right? Look in a little bit more detail that the efficiency of this algorithm is highest during the first trimester. Why? Because D-dimers are more predictive in the first trimester, and they avoided CTPAs in 65% in the first trimester and 32% in the third trimester. This is a systematic review of D-dimer to rule out VTE in pregnancy. Again, it's from the Canadian group, and they found 3 prospective and 1 retrospective study, and they had variable D-dimer cutoffs, but they showed that the 3-month VTE rate in pregnant women who were left untreated after a negative D-dimer was low, was 1 in 300, 0.32%. So they concluded that up to 18 per 1,000 women with suspected VTE could go on to have a VTE. Now, if 18 in 1,000 women are going to die as a result of that VTE, then I would argue that that's not okay. But from a statistical analysis point of view, the negative predictive value was 100%, although I've shared with you a case where it wasn't 100%, and the sensitivity is also very high. Now, Beverley and I were both involved in the DIPEP study, which was a UK-based study comparing women diagnosed with confirmed PE. This was a UK-wide study, and comparing those women with suspected VTE, PE, who were investigated. And it looked at the value of D-dimer, and it looked at the value of clinical decision rules. And first of all, for D-dimer, these are the ROC curves. And we found that different D-dimer assays had a very low sensitivity and specificity for ruling out or ruling in PE in pregnancy. And for the clinical decision rules, we looked at lots of them. We looked at the PERC rule, the simplified Geneva, the Wells score that's been spoken about already this morning. And then we thought, well, hang on a minute, these clinical decision rules are not really written for pregnant women. Let's make up our own. So I'll talk about the clinical decision rules in a minute, but we developed our own using a Delphi consensus model. But even the bespoke pregnancy clinical decision rule was not good. That's the pink one you can see. It was the red one. It was not good at excluding DVT. So we concluded that a combination of D-dimers and clinical decision rules was not good enough at excluding PE in pregnancy. And then we thought, well, let's take our cases and apply the other published strategies. So we had 12 out of 200 women, 5% with a confirmed PE. And if we'd used the Dutch strategy, the Artemis strategy, we would have discharged 43% of our women without scanning, but 5 out of 12, that would include 5 out of 12 who had a subsequently confirmed PE. If we used the Canadian study, we would have sent home 1/5 of the women without scanning, but those 12 with PE, 3 would have been sent home. So either strategy risks missing women who have been confirmed to have PE in pregnancy. So the argument was then brought to us, well, hang on a minute, in your study, a lot of the women with suspected PE were given a treatment dose of low molecular weight heparin before they were scanned. And the treatment dose of low molecular weight heparin would have affected the D-dimer result. So we then looked at the 2 women who had a PE and hadn't received anticoagulation before the D-dimer test. And both these cases were categorized as PE, but would have been ruled out using the other strategies. So this is an actual example from the DIPEP cohort. This woman was 25, she was 15 weeks pregnant, she was obese, she had pleuritic chest pain and shortness of breath at rest. She didn't have hemoptysis, she didn't have clinical signs or symptoms of a DVT. Her heart rate was 100, respiratory rate 20. Her Geneva score was therefore 5. PE was the most likely diagnosis. That was her D-dimer level. And she would have been excluded from scanning, and she turned out to actually have a PE. So let's look at the clinical decision rules that were used in those 2 studies. So if we look at the Geneva score, I have looked after pregnant women over the age of 65 once. So that's not really relevant. Active malignancy happens in pregnancy, but it's rare. All pregnant women, nearly all pregnant women have a heart rate above 75, and many have a heart rate above 94. So the existing clinical decision rules really don't work in pregnancy. What about the years algorithm? Well, signs of a DVT are very helpful, and no one's going to dispute that. Hemoptysis is rare, but nosebleeds are very common in pregnancy, and some women can cough up blood that has actually come from their nose. So the years algorithm is not a really good clinical decision rule in pregnancy either. Now I'm going to come back to this issue of the timing of fatal PE. I've told you that fatal PE is actually common in the postpartum period, where 2/3 occur. But if antenatally It's clustered towards the first and second trimester and not in the third trimester. And if you look at all the maternal deaths from PE since 1994, the vast majority of them, a third of them, have happened in the first trimester. Remember what I told you about the D-dimers in the first trimester. Now look at two cases from the confidential inquiry. Both these women went to the emergency department. One went with leg pain. Her D-dimers were 20-fold above the upper limit of normal. She had a negative leg Doppler, so that was assumed to exclude a DVT despite clinical suspicion and a very high D-dimer. She went back to her GP with leg pain, but that didn't prompt evaluation. Remember what was said earlier about pain. A DVT was finally diagnosed. Unfortunately, an inadequate dose of low molecular weight heparin was prescribed, and that woman died of a PE. This woman was referred by her GP with a suspected PE. The diagnosis was made of chest infection despite her chest being clear and a very abnormal D-dimer. The chest x-ray was omitted with a comment, unless necessary, it should be withheld because of pregnancy. Back to the issue that you should never leave out the chest x-ray. The obstetric team weren't informed, even though the GP had alerted them that the woman was coming. And this woman died of a PE because she was misdiagnosed as having a chest infection in ED. So this is a published clinical diagnostic algorithm for PE in pregnancy. It's largely what I practice, and it's very similar to the one that Beverley showed you with the omission of D-dimers. So it all hinges, as I'm sure you've by now worked out, on who you suspect of having a PE, as Beverley was saying early on. And this involves a clinical gestalt of history examination, ECG and chest x-ray. And you need to be able to work out which of those multiple women with breathlessness are describing physiological breathlessness of pregnancy, which I can do very easily because I work with pregnant women every day. They have air hunger. They can't finish a sentence when they're speaking, but they can walk, go take their dog for a 2-mile walk without any difficulty whatsoever. It's differentiating, as I said at the beginning, the needle in the haystack. In terms of management, I'm not going to go through that because my remit was really to talk about diagnosis. So I want to finish by saying that, reminding you that pregnant and postpartum women are at increased risk of VTE, including in the first trimester and particularly after first trimester surgery. D-dimers and clinical decision rules don't have a high enough sensitivity or specificity, in my opinion, to reliably rule out. And if you take sensitivity and specificity, how many is it okay to miss? That's the issue. Never leave out the chest x-ray in pregnant women. Both CTPA and VQ scans are safe, and MRV is really good, useful if you're suspecting iliofemoral DVT. So I'm really, really sorry about my internet. I'm sorry about it. Always, never, ever, ever goes down. But of course, it goes down when I'm in mid-flow. But actually, amazingly, we've still got 8 minutes left. So
wonderful, Cathy. Thank you for that. And really, you've explained why in the UK we diverge from the European guidelines, because we think they're almost right, but they may miss a few PE. And we can't be missing a few PE in pregnant ladies because the consequences can be dire. But that's our view, isn't it? And there are people in the chat who aren't altogether agreeing with us, and that's fair enough.
I do think, before we take the questions, I do think we need to be a little bit more finessed, and I've implicated but not actually said that in the first trimester, I think it is possible that we could use a combination of clinical decision rules and D-dimers. I've shown you evidence of that, and that's when these women are presenting to ED, which is where they get the D-dimer done anyway. But I agree with you, Beverley. I don't think we can use it in the second and third trimester.
Okay. Oh,
never simple.
Good question here. Do you agree we need better networking to work together in PE in pregnancy? It's sounding more a OBG diagnosis rather than a medical one. Do medics need more education on this? And it's from Deborah B.
Yeah, to absolutely. I mean, I've said, you know, arrogantly, I can spot pregnancy breathlessness. You can as well, Beverley, because we spent a
No,
lot
not
of,
always. No.
well, I can. I'm really confident. I can send
Good.
women out of the consulting room because they, I mean, not always, but if I'm worried, I'll exercise them, do their oxygen saturations, which is another, if the symptom is breathlessness, and you exercise them and their oxygen saturations don't drop, that is a cheap, easy rule out test. The problem is those women who present with pain. I do think we need to work closer together. I do think that physicians and ED doctors need more specific training in pregnancy medicine. That's my whole raison d'etre. And obstetricians are pretty good at this. And you know, the difficult, hopefully maternal medicine networks, which if you work in England, you will have heard about, they involve GPs, ED doctors, physicians, hematologists, obstetricians, obstetric physicians working closer together and communicating. It's about communication. I showed that last case because the GP made the diagnosis and was then promptly ignored in the ED department, who didn't call the obstetrician. That is a total failure of communication. You know, and we're not always right and we miss stuff, but if we work in teams and you get a fresh pair of eyes, it's sometimes easier.
So this is the other thing you said, which is really interesting, which is something I do, is that if people are complaining of breathlessness, I walk them down the corridor. I've got a sloping corridor outside my office and back, and I measure their saturations.
Yeah.
You're doing that. It's in no guideline. It's never been properly evaluated. I think that's a little project for us, isn't it?
Yes. There is one paper, there's one paper describing its use, but we're going to need, it's got to be big to, and we're going to have to probably scan a few women to prove that we're not missing it.
Anyway, so that's a lifetime project. I'm going to read you something slightly allied. In patients who develop a VTE whilst on estrogen-containing pills, a discussion at BSH recently concluded that these women could carry on with the pill whilst anticoagulated, given high risks of thrombosis with pregnancy, which I think we would all agree with. However, a survey of what is actually in practice showed that the majority of those patients were asked not to take an estrogen-containing pill following VTE, regardless of anticoagulation. Any thoughts on this?
Yeah, I mean, it would be my practice to switch over, and I'll tell you why. Because the modern progesterone-only pills and the alternative forms of contraception that are available to women negate needing to use estrogen. So Matthew will help me with the name of the contraceptive guideline, FSRH or something like that. They are very, very clear. Why give estrogen? Why risk further clots when you can give a non-estrogen containing really effective form of contraception? So I disagree that you should continue estrogen in that scenario.
I agree with you. And the progesterone pill is marvelous, although some people don't like it. They don't feel well on it.
They don't like it, but...
so they can always go back to the estrogen-containing pill. And of course, the Mirena coil is a joy.
Yep. And now there's a small one that's less painful for primiparis women. The implant, the Nexplanon. I mean, GPs know about this. They know about long-acting reversible contraception, and they will take those women off estrogen because that's what they're taught to do. And I agree. Matthew, would you do this?
I absolutely agree. I mean, we actually, in a lady who wants to separate children by a significant few years, we wouldn't be advising pill anyway. We'd be talking about coils, we'd be talking about implants. Our whole conversation is not about estrogen pills over it's about the whole of the contraception array that's available, and actually trying to encourage women to use longer forms of contraception if they want gaps between their kids.
Yeah, I mean, the other thing, you know, we have to think, Beverley, why is that death rate? Why are women dying now? Why are so many dying? And obesity is a big part of it.
Agreed.
And postpartum obese women, the last thing in the world they need is an estrogen-containing pill. It's like the straw that breaks the camel's back.
Yes.
You know, I don't think I virtually never recommend the combined pill in my clinical practice anymore, because so many of our patients are obese, and it's
Yes.
combining risk factors.
And there's some new data. Many of them who are obese have polycystic ovary syndrome, and that's an added risk factor for VTE. So if you're obese, you've got polycystic ovary syndrome, you don't really know you've got it, and you have the combined pill, it really increases risk. Matt, I didn't mean to exclude you. I didn't realize you were online. Kathy, here's a cryptic one. Anonymous attendee. It would help if Royal College of Obstetrician guidelines could be updated.
Yeah, that's not cryptic at all. I've done 3 lots, guys. Okay, I am not doing another one. I aged and went grey in the process, and I do deeply feel for those people who are writing it, because, as you know, Beverley, the evidence synthesis analysis that we were involved in would suggest that, well, on face value, it shows that low molecular weight heparin isn't indicated because risk, benefit, expense, etc. But it's more nuanced than that, as you know. So on the one hand, we're dishing it out to 40% of postpartum women. And on the other hand, we've got an increasing death rate. So something has to give, something has to change. We have to get better at risk assessment. And instead of just blanket bombing all postpartum women, we need to probably be giving extended prophylaxis to more women, and not necessarily giving it to so many women. But to answer the question, you know, guidelines are only guidelines. And I come back to, I'm going to say something like, make me sound 108. It's all down to the clinical history, as you and Matt have both said. And that is all down to being a doctor and taking a history and listening, and sometimes breaking the rules and thinking, okay, this is the guideline, but in this particular case, I'm going to break the guideline because I'm really worried about this woman for X, Y, or Z reasons. And therefore, guidelines are there for counting things, to help midwifery and nursing staffs risk assess. But they are oversimplified. They are then changed by every single trust who decides they know better. And that's why I think they don't work.
Right. Perfect ending to perfect session. Hooray, Kathy. Hooray. Thank you, Matt. Thank you, Joe, for organising this. We're 2 minutes over. Thank you.
Sorry, Joe.
Wonderful audience, 422.
Yeah.
I hope many of you will come back in a quarter of an hour to hear about the new spontaneous fit syndrome. Or is it new?